Good morning. I'm standing up here talking and there's so much talking in the room that no one's paying attention, which is great. It is so good to see you all here and see the buzz in the room, and I appreciate everyone coming along. My name's Patsy Yates. I'm Executive Dean for the Faculty of Health. I want to welcome you all here to our Real Health, a part of our Real Health lecture series. This morning we are addressing a really important topic, and we've got a fabulous range of speakers on the panel here today. But before I do start, I would like to acknowledge the traditional custodians of the lands on which we're meeting and pay respects to elders and play just a short video of our welcome to country. Okay.
Balka be Balka, welcome in the language of the Yagara people. We acknowledge the Turrbal and Yagara peoples as the First Nation owners of the lands of where QUT now stands. For thousands of years, the Turrbal and Yagara people have gathered along the banks of Maiwa, the Brisbane River, to share their knowledge and stories. We pay our respects to their elders, laws, customs, and creation spirits. We recognise that these lands where QUT now stands have always been places of teaching, researching, and learning. We acknowledge the important role Aboriginal and Torres Strait Islander people play within our QUT community. From Moreton Bay, inland as far as the Great Dividing Range near Warwick and Toowoomba, as far north as the Caboolture River, including the lands around Brisbane City, Meanjin. Yura yura yinala, balka bi balka, nganguru nguru maramakoro nganya birali, nganya bayam. Welcome to the traditional country of the Turrbal and Yagara people.
So that is a wonderful video that Uncle Chegg, our elder in residence, prepared for us, and it's and we always like to open these events with that important acknowledgement to the Turrbal and Yagara peoples. So today I would like to welcome. We've got a wide range of people in the room here and online. We have people from our community, older people living in the community. We have a range of clients and consumers of some of our aged care services in the room. We have some of our colleagues in working in aged and health care in the room. We have a number of alumni, and we have a number of our sponsors for various prizes and awards and other activities that we do within the Faculty of Health. So welcome to you all, and welcome to those people online. I do want to start also by acknowledging we've got two apologies for today. Unfortunately, as we know, things sort of crop up and people are unable to attend. So an apology from Jean McGreevy, who is actually president of COTA. She was hoping to join us today to provide that consumer perspective, but hopefully she's listening online, and I know Darren's going to actually speak some words on her behalf. Also, Professor Elizabeth Beattie, who, again, due to personal reasons, isn't able to be here with us today, but we're very fortunate that Associate Professor Margie McAndrew has stepped into Elizabeth's shoes. Margie works very closely with Elizabeth and will be presenting and talking about some of the issues that she and Elizabeth have been working on. A couple of housekeeping items before we get started. Just note that the emergency exits are there and there, and they just go out and down through the stairs if needs be. The restrooms are right down the end at the right, on the right, if along the hall. And another bit of housekeeping, if you've managed to park on campus and find your way to the building, and if you haven't already done so, please just ask reception and they'll have your parking ticket validated and give you instructions for how that works. So this is part of our Real Health lecture series, which we launched in November last year, that we really want to contribute to the community by providing forums where we are discussing key issues of relevance to the health of our community. So we've had, this is our fourth in our series, and we've discussed a range of different topics. And for this lecture, what we're bringing together thought leaders from research industry and the community to discuss and debate some bold ideas and discuss some think about some solutions to many of the complex challenges that we're facing in health. And today, the topic, as you know, is on ageing with dignity. So this morning, our panel comes from a range of different backgrounds, and I'm going to introduce them in a minute. But in particular, that we're really looking at this coming off the back of a significant change that is in the winds because of the pressures that we have on our aged care services, both community, residential, and just the way in which we organise care for people in our community more broadly. We know that the Royal Commission, which happened pre-pandemic, and the report came out, in the last couple of years, has highlighted some really critical issues that confront us as a community in terms of, and that really are requiring us to step up. So today's talk is going some way to perhaps actually contribute to that conversation, have an opportunity to share some thoughts with some experts and have your input so that we can continue to ensure that we move towards addressing some of the challenges that we face. So, and I'm really excited to hear what the panellists have to say today. As I said, we've got a broad range of expertise here, and I'm just going to maybe introduce them before we proceed. And the structure for this session is we've got a couple of questions we're going to ask the panel, but we will then provide plenty of opportunity for you to ask questions, and people online are also able to ask questions as well. So first up, I'm going to introduce Wendy Zernike. So Wendy is Executive General Manager for Bolton Clark, and for those of you who don't know, Bolton Clark is one of the largest independent not-for-profit aged care providers in Australia. Wendy is an RN who has worked in a wide range of areas in health and aged care for many years, and she's got a particular expertise around clinical governance. Professor Alison Nudge. Alison is a general physician and she's currently the Clinical Director of Research and Education at the Department of Internal Medicine and Aged Care at Royal Brisbane and Women's Hospital. Alison is also the clinical lead for the Eat, Walk, Engage statewide delivery and prevention program, and so maybe Alison will talk a little bit about that if we get a chance, but I'm sure if you want to know more, Alison can talk to you about that really important program as well. We have Darren Young. Darren is the CEO of the Council of Ageing, COTA, Queensland, and all of probably 2 months now, Darren in that role, I'd say, yeah, something like that. Darren has a background working for large not-for-profits as a manager of rural, residential aged care facilities, community aged care and retirement villages. Thank you for joining us, Darren. We have Associate Professor Margie McAndrew. Margie is an Associate Professor in Aged Care and Dementia here at QUT School of Nursing and is stepping in for Elizabeth Beattie, as I said, who couldn't be with us today. Margie has extensive experience as an RN in aged care, aged and dementia care, and she's leading quite a significant program of research that's focused on dementia care and improving the quality of aged care. And finally, Jane Phillips, Professor Jane Phillips, who's the head of the School of Nursing, also here at QUT. Jane also brings an extensive experience working in a range of different policy, education and clinical areas in both community, acute and chronic, and working with a range of chronic conditions. So Jane brings a range of research and policy and practice experience to talk with us today. So with all of those introductions, now I'm very keen to sort of jump into the discussion that we're going to have, because the time will go very quickly. And I've been warned that these folk with all their extensive experience have got a lot to say. So, I'm going to start with Darren because Jean, who was going to be here as she's president of COTA Queensland, was going to be here as a consumer representative, couldn't be here. But I'm wondering if you're able to let us know if, Jean's passed on to you some thoughts. And the question that we had asked Jean to think about is just as a way of starting, to tell us about what living well with dignity looks like.
Thanks, Patsy. Jean's the chair of our board. We've had a chat before this meeting. She speaks with a lovely English accent. I'm not going to be able to replicate that, unfortunately, but she's really passionate about this topic. When we think about ageing with dignity, and if you close your eyes and you think, what does that mean? And what is the image that comes to mind? you're more likely to think of a person in residential aged care. You're probably thinking about someone who's in bed or in a chair, staring out the window. It looks a bit wintry. That's can't get out, can't move. Jean's saying that's not us. Jean's saying that's about that much of us. What she's saying is that we're living longer, we're living better. There's only, I think, over 85, I think there's 1 in 4 people who will experience being in care. She's saying lots of people, including herself, are growing older, living very active lives, connected to family, connected to community, making a very meaningful contribution. And so she gets pretty annoyed when there's all this conversation about, what are we doing with our elderly? What are we doing with people who are aging? And she's saying, actually, a whole lot of us actually are okay. So that's the first thing. She's saying stereotypes don't serve us well. And she would say there's a lot of living to do before you end up being in an residential aged care bed. And she said we should be talking more about that. She also says not everyone ages the same way. If you put 2 people who are 65 years old, 75 years old or 85-year-old together, their abilities, the way they'll live their lives is very different. So she said, don't make assumptions. And she says that when she encounters people, or when she encounters younger people, she feels people are making assumptions. So she thinks if we want to age with dignity, we've got to let go of the notion of age. Age as a number doesn't mean too much for us. Think about the individual, think about the person, and that's what will lead to, for people as they grow older, to have dignity as they age.
Thank you, Darren. And I think that's a really important message that we want to pick up on today, is that really some of our perceptions about that this is a single group in a residential aged care facility really presents some of the challenges we need to overcome. So we will explore that. And I think it probably leads nicely to you, Wendy, if you could sort of maybe share with us what living well in the community with dignity looks like from Bolton Clark's perspective, from an aged care provider's perspective.
Thanks, Patsy. I think I'd like to add to what Darren said. Darren, you're saying it's only, or Jean is saying it's only a small group of people. At Bolton Clark, we have 70 residential care facilities. So we have over 6,000 people living in our aged care homes. But if we look at our home care business, we are making 3.5 million visits to people in their own home a year to 43,000 clients across Australia. So it is only that little bit that are living in residential care. So what does dignity look like? It's about the person, and the way we approach it at Bolton Clark is that we have an approach to ageing and a model of care that looks at that everyone can learn. So there's like 5 principles around that. So how do we get this consistency across our staff? Is that when they're engaging with someone in service, is that we're not service-centric, we're more person-centric. And an example can be really practical. Our principal wellness and reablement advisor, Kath Payne, she's online today. Hi, Kath. She gave me an example yesterday when I was preparing that we've got a client who has cleaning once a week, and that's what she needs to be well and live in the home. Her dog passed away. So she said to her, to our staff member, I really want to go to the dog park. I want to see dogs run around. So she stopped cleaning that day because that's what the client wanted. And they now regularly go to the dog park together. So we teach our staff that every individual brings value. They have their own life experiences, and definitely they all age differently. So we have an approach that's positive aging, or even maybe more accurately adaptive aging, because not everyone is going to have a positive experience. It's about how they adapt to the aging process. that keeps them as independent as possible. And we know through research that it's not a genetic factor that influences how people age, it's more their lifestyle. And what the research is saying is the most independence that you can keep will actually, you will live longer, you will live better. So that is the approach of, how we approach our service. There's always that when sometimes risk and duty of care don't align. So we also use a dignity of risk process. And that's all about having those honest conversations with the person that we're caring for and what risks they would like to take and whether we're able to assist them with that.
Thanks, Lynn. Yeah, I think that ageing differently and the complexity and the challenge then of and dignity of risk has been something that is being discussed a lot at this point in time, because it really is about how we're able to think about people's preferences and choices, but also help have conversations, honest conversations around what that might mean. And they're very, very hard things to do, of course, aren't they, Wendy? And so if we get time, I might come back and actually ask you to talk us a little bit about some of the programs that you offer to develop those skills. But we might just move to Alison now, because I think we also think about, where aged people are, and we think about they're living in their homes, they're maybe in some in residential care facilities, but of course at some points they have interfaces with other parts of our healthcare system, and that's where Alison's work is really working in an acute care facility. And so, Alison, we know that COVID-19 has disproportionately affected older Australians and put further strain on the aged care system, particularly at those interfaces of health and aged care. And so, I was wondering, what that actually has meant and what's, how's that changed priorities for living well and what dignity might look like for families attending, for individuals and families.
Yeah, thanks, Patsy. And obviously, the pandemic has had profound influence on health, as it has on many other aspects of our life. I think one of the most interesting lessons for me is that, people made a really enormous commitment to the health and safety of their families and their communities. So people were prepared to sacrifice almost everything, weren't they? Early in the pandemic, they were happy just to risk their work, risk their businesses, risk their friendship groups, risk their socialisation for health. And I think that that's a really interesting message that hasn't really been capitalised on, that people said, yes, this is the most important thing. And I think there's often, a lot of political fear about how much people are prepared to invest in health, but we have seen that people are very serious about the health of their communities and their families. I think we were very fortunate in Queensland that in 2019, just prior to the pandemic, we had very substantial investment by the state government in hospital and interface models, including acute, advanced care planning, residential care outreach and in-reach services, and emergency department and inpatient models, and that really set us up well. And I think that there's been some extraordinary work through those mechanisms in the hospitals to try to maintain that balance of risk and care between the hospital and residential care. But I would still say that some of those models still do bring that risk of stereotyping and ageism, and in particular there remains a very strong policy emphasis in older people on keeping them out. And I just wonder whether that would be an acceptable policy approach if we said, let's keep 20 to 30-year-olds out of hospital, because it's not good for them to be in hospital. It's not good for anyone to be in hospital. It's undignified. It's, we give great care within very difficult confines. But for me, my passion is always about how do we, rather than say that approach should be to keep older people out, because we haven't built hospitals well for older people, how do we actually create hospitals and care models that are good for older people, because they're our main client? And that's certainly what our Eat, Walk, Engage program is about. Very baby steps, I'd have to say. And I think as a community, we need to capitalise on some of the opportunities that are happening around, particularly around building new hospital wards throughout Queensland that we're all seeing on the telly. We need to make sure that they are designed well for older people, that they use all the principles of visual and cognitive and physical impairment, so that we're not setting up continual cycles of disabling care within our hospitals. So there are a lot of things we could be doing as a community to improve that in-hospital care. And while we don't think of hospital as part of living well, it is inevitable as we all age that we will have the need from time to time for acute care, and we need to make sure that that doesn't become a major destabilising and disabling influence in our lifespan, but that it continues to support us to get back well in the community.
Thanks, Alison. Maybe can you talk a little bit about that Eat, Walk, Engage program, because it is extraordinary what it's trying to do and it's quite a different sort of model in an acute care facility. So just maybe.
Yeah, so Eat, Walk, Engage is really a program to try to support staff on a ward to deliver better age-friendly principles for older people, and that includes, so we call it Eat, Walk, Engage, because if you can get people eating and drinking earlier normally, get them mobilising earlier within the limits of their disability, and very importantly, giving them something meaningful, cognitive and social activity in hospital. We know that that dramatically reduces hospital-associated complications, and in particular delirium. So we've shown that it reduces delirium by half. Delirium's where you become acutely confused in hospital, and it is the most common complication of hospitalised older people. And it leads to future dementia. It leads to about 30% higher nursing care needs, so it's got a big impact on our acute care system. It makes you much more likely to need rehabilitation care and aged care, so it's got lots of post-hospital implications. But most of all, it's terribly distressing to patients and their families. So it's a model that can reduce delirium by half, where we've been able to expand to 2 wards in many of the major hospitals around Queensland, but there are many wards that still don't have this model. And you know, our dream is that every hospital ward in Australia will care for older people using this model of care, and it includes education of staff and adjusting the physical environment and thinking about how our roles intersect, and it involves some very difficult conversations with staff, but it's a very effective grassroots intervention, and it's driven by the voice of the consumer. So we always interview older patients on the ward about what the experience is like and use their comments, suggestions and barriers to drive our interventions and our improvements. So to create continuous improvement driven by older people in hospital. Always happy to talk about it.
And I think this is again a great one of the sort of examples of these types of transformational changes that we really need to do. We need to sort of turn on its head the way in which we think about acute care and actually recognise that that those old models don't work. And what have you learnt about how to actually make such a model sustainable, though, because it is both a cultural and a structural and very different sort of way of thinking about how we provide hospital care?
Yeah, absolutely. So these models do take resourcing and skills. So there is a continuing cost, and we've been very fortunate to have some support from the state government around that. But I think the reason that there's a continuing cost is because we're constantly up against this societal barrier of ageism, and we need to also be, so parallel with these models, we also need to be really addressing why there is almost no gerontology teaching in any of our undergraduate curriculums. Why do we not actually have any evidence base around how you would feed someone who has acute delirium or how you would walk someone who has acute delirium? Because these are practical challenges our nurses face every day, and yet we have no empiric evidence about how to do that best. So how do we, so there's still a lot of teaching, learning and research that needs to underpin, and until we have a really skilled, compassionate and non-ageist workforce, which is a lot of work for us in education, we're going to need to keep coming in with models that constantly reframe for our staff. But as we evolve, we would hope that they become less necessary. Yeah.
Oh, thanks. And maybe I might go to Wendy now, because I think we've just heard of some sort of examples in an acute care system, maybe from community care. Have you got some examples you could share with us?
Definitely, Alison. Look, that's really interesting. And on the back of what you have said, I guess we're all sick of talking about the pandemic. It has had such profound results and impact on the community, and I think we could all agree that the older person here has, in many ways, suffered greatly. What we saw in our community care services is falls went up like this. So we measure that, and it was actually related to frailty. So because people wanted to be safe and secure, and they were safe and secure, the price to pay for that during lockdowns is if you lived in a small home, where were you going to walk? So a lot of the work that we were doing during the pandemic, and we're still in the pandemic, is around the reablement now and the programs that we're running to keep people well and to keep them moving. So a couple of examples of that is we have a Be Healthy and Active program that was a face-to-face program that we just reached, I think, our 20,000th person that had been through that program. We actually videotaped that with our Altura Learning company and put that online, and actually helped individuals do that in their homes to keep their conditioning up. We also have an Enabling Choices program as well that we discussed with the families and people in their own homes, how they could be active and what they could do for themselves. We had to really pivot our service. We had a lot of staff that were off with COVID like every other industry. But what we did with those people, we have a lot of registered nurses. We had them making wellness calls and coaching our clients on the phone about how they could keep well. It went really well. We've continued that, and in order to deliver the service, especially in those early days when people really didn't know, how do you keep your staff safe? How do you keep clients safe? That we would make calls prior to going into the home so we could prepare for that. That's actually one of those legacies that is staying. And I think on the back of this healthy and movement in acute care, we're also looking at social prescribing. So we stood up a program called How Are You, which was already underway, but it catapulted when COVID started, and it's now running today, and it's turned into a corporate volunteering program. So we actually, we've got over 100 of our corporate staff that ring clients every week just to have a chat. So it's completely volunteer. We're connecting with our clients and they're absolutely loving it. So there is definitely, I think, one of those lessons learnt. Alison, you were mentioning lessons learnt. I think globally, one of those lessons learnt from the pandemic is the importance to take mental health seriously and that social connection. And Patsy, I think you're talking about as well, I think for people who were connected in the community prior to the pandemic realised how important that connection is. And for those that didn't have connection, they also learnt that they needed it. So to keep that going, that's one of those silver linings. And if we reflect on the pandemic, there's so many of them. I mean, the obvious one is telehealth. That just seemed to be so difficult before, that has just given so many people more access to healthcare.
Thanks, Wendy. So some great examples of opportunities we have to really transform and do things differently to achieve ageing with dignity. And I'm going to go to Margie now, and I think perhaps because again we often don't hear about these good examples of what's going on. We often hear about the other side and what are all the problems and challenges that are real problems and challenges. Our Royal Commission has said that to us, and so. Margie, with your extensive experience working in aged care and as a researcher and educator and trying to actually do what Alison talked about, sort of really address, ageist sort of perspectives in some of our courses. Can you maybe talk to us what you see were some of the key issues that came out of the Royal Commission? And then I'm going to maybe ask you to sort of pick one or two as to what might be some solutions. Yeah.
Yeah, and it is great to hear about the great programs that are going on, but the Royal Commission did highlight what isn't going well. We shouldn't lose focus, though, that there are very good providers of aged care. There are very passionate providers of aged care, and we can't lose sight of that, but we can't deny that
there is gaps in the quality of care that we are providing. I was asked to think about the issues, and I came up with 4 pages of issues and had to try and get that down to 3 minutes. So I've focused on 4 points, but obviously there are lots of things to consider here. The first one being that people are living longer. There's a supply and demand issue. We don't have enough aged care services for the number of people needing it. And the services are not actually keeping up with the needs of these people yet. We're caught back in an age where aged care services were there to socialise, to be that person who comes in and tidies the house, and maybe the old bingo games at residential aged care. People are seeking help much later because they are living healthier, but once they're accessing services, they're much more unwell and they have multiple comorbidities. And so the care they require is very complicated and complex. And at the moment, not all the aged care services are keeping up with that. From the aged care, from the Royal Commission, we also heard that people can't access the services either. They're not able, they're getting their packages, they're getting the freedom to use those packages the way they want to use them, but then they can't get on to get those packages, to get the services they need. And with privatisation, some of those services are out of the ordinary person's reach. And so there are people, again, who are waiting too long to get the services they need. And by the time they get the services, it's often too late for them. During the Royal Commission, there were the stories of having to wait for years and then the person was deceased once the services became available. Lack of financial commitment from the governments. To really tackle these problems, we do need this enduring commitment from governments, from both federal and state. It's a huge problem and there isn't the magic wand that's going to fix it. And the profile of people accessing aged care has changed significantly. Look, if we look at the population of people going into residential aged care, most of them, the average age is I think now 82. They're going in much later and their care is very complex. And the average length of stay is only 30 months. So they're receiving palliative care in nursing homes now, yet the people who are caring for them, the health professionals, the regulated health professionals and the unregulated health professionals aren't prepared for that level of care that is expected. So there's lots of problems. And I feel like this one that's now brought down the tone because it was very positive until
so what do you see might be some ways forward?
So certainly looking at education, the training that people have, and changing that mindset that aged care is easy. Anyone can do aged care. Well, no, it is a specialised field. It requires specialised training, and yes, we do need to train our undergraduates, we need to train our doctors, we need to train our allied health professionals. But more importantly, we need to train those who don't go to university. So the personal care workers who make up 80% of the workforce in aged care. They may have received 3 months training before they hit the ground. They rarely receive any dementia care training. They have a little bit of aged care training. They certainly don't have the level of training they need to be able to notify the one RN looking after 60 residents that there is a problem. So that's the first issue, but also looking at the pay disparity that we have and the ratios that we have in aged care in particular. I could go and work at RBWH and get $59 an hour. If I go and work at the local nursing home, I'll get about $50 an hour. The work will be harder in the nursing home. I've worked in both. I know the work is harder. My skills are the same going to both places, so why would you pay me less? So until that disparity is addressed and the knowledge gaps are filled, then we're not going to get the people there that we need to be providing the care, and our ratios will continue to be ridiculous. And yes, errors will occur because of that.
Thanks, Margie. So we've talked about our aspiration, and we've heard from Jean's points about living and what ageing with dignity looks like. We've heard about some opportunities. We have some different types of programs and things that are already happening, and Margie's presented to us maybe some of the challenges and barriers, structural barriers, significant structural barriers. So I'm maybe going to ask Darren now, because in your role, you're an advocate for change and the sort of solutions that we need to improve how people can live well in the community and with dignity. What changes and potential solutions do you think that we can implement to ensure people can stay well?
I feel like I'm in the same position of having written 15 pages before this, and where do you stop? But I'm going to do 2 points. Firstly, I think the good news is we don't age overnight. Some mornings might feel like that, but apart from that, we don't age overnight. There's a long time. There's a lot of living to occur, and we know what aging well looks like, and there's a playbook. So there's 5 things. In my mind, there's probably more, but there's 5 things. So if you think about, and these have policy implications for us, and we should be thinking about it and talking about this as a community. So the very first one, meaning and purpose. So for me, when I start thinking about meaning and purpose, and I came into the helping profession, we often see people that turn to helping, and I've got a relative who's 90 and he walks across the road, and he, in fact, used to be one of the aged care facilities that I ran, and he helps the older people with their meals. I suspect he's trying to get a free meal, but for him, that's what gets him out of the bed in the morning, and he dresses himself and he's feeling good. That's his meaning and purpose. So we've got to think a fair bit more about that. Diet, exercise, very important. We know a lot about that. What we probably know is perhaps not critical. It's good. We want to have good diet and good exercise, but we can still have that glass of wine and the chocolate occasionally as well, and we don't have to go to the gym 5 days a week. The big one is around social connectedness, and that's the one that we're underplaying very much. We've got to do a lot of more work on that. We know, the term silent killer is often used, where we're not enabling people to socially interact or have new social interactions. We know the new social interactions. In fact, if you're going into a residential aged care facility, make sure if you're passing someone, you say no, say hello, because as soon as you interact with someone who's new, all the new networks are firing in your brain. It's a quite highly stressful thing meeting someone that's new for the first time. It's actually really good for us. So as we get older, we don't want to be hanging around the same people. We've got to invite a few other people in, a bit like my mother-in-law who'll talk to the postman and talk to the bus driver, and she's going to live really well, because we need more of that social interaction. And the last one, it's a bit more of a difficult concept, but one we kind of know a bit about, which is sense of belonging. This think worth, think place, think connections with family, think about value. Am I being valued in community? And that's also tied into, if we've got a community that doesn't value older people, your sense of belonging is going to diminish. So we've got to think more about what messages are we giving people in our community? How are we valuing our older people? What's their place in community? How are we connecting? That's point number 1. Point number 2, look, we should all be advocates for ageing well, and that should start very, very young in life, but eventually we will lose some level of ability. If we're lucky enough to live that long, we'll lose some ability, we'll start to lose a bit of independence. One of our first encounters with the aged care system will be having some level of support and perhaps some care in the home. Now, if you've been watching the news, you've just seen the Jobs Summit. You've been hearing aged care in crisis being used. So for us, at CODA Queensland, and we've been watching the space for a couple of years, the workforce challenge, I think, can't be ignored. We can't separate that. If we want to age well, we've got to be thinking about how do we bolster our workforce over the coming 10 years. And we know there's quite a large shortage, 110,000 worst case scenario by 2030, that we're going to be short of workers in the aged care space. But it's not just about having enough workers. And I know, having worked in residential aged care, I remember the first time I met a batch of people that just came in and they've just joined, no one had older people in their families and no one had actually interacted with older people. So like I was kind of shocked by that, that we're about to have a whole group of people coming into our facility. Yes, they've had some technical training, but there's more to it than that. Is how do you build rapport and how do you have a conversation? How do you be person-centred? So Coda Queensland is doing two things. One of the things we're doing is we've partnered with a couple of other companies where we're raising the numbers of personal care workers across Queensland. We've got some good methodologies to do that. In fact, we're just connecting individuals to RTOs, to providers, and we're getting that happening. But our other interest is we're bringing on people who have had lived experience of being cared for or lived experience of caring for others. And we're bringing them on board, and we're developing materials. We're developing podcasts. We're developing opportunities for older people with lived experience to come and talk to students, engage, and even we're doing some mentoring work with the students as well as once a person gets in as working as a personal care worker, giving them that support, encouragement, a bit of a touch point for them, because we can't have just the uplift of numbers without getting the culture right for people to go, let's be person-centred. It starts, as when you would know, it starts from day one. When you're working, you want to get into good habits and good ways of interacting with people. So we're encouraging that as well. So those two things I think are really important for ageing.
Yeah. Thanks, Darren. Really, really important points. Jane, I'm going to ask you now, sort of again, thinking ahead, what you see some of the exciting changes that might be happening, and how we might take advantage of some of these sorts of ideas that have been discussed today.
Yeah, thank you. It's been great to listen to my colleagues, and I guess probably my pitch for today is to think about the future and think about what technology may be able to offer us as we're ageing. And if we think about ageing with dignity, to me it's actually being as well as possible for as long as possible and being in my preferred place of care, which for me will be at home. And I think that we've got some technology that we can probably actually really harness to enable people to have social connectedness, to maintain their networks. But also, I would really like to think about co-designing technology with key stakeholders and having older people at the centre of that, to think about how do we actually get timely support to these people. I'm thinking about the patients, the people Alison might see in the acute care setting, but many of Wendy's caregivers may have actually noticed that this older person at home is a little bit muddled, might have some of the early signs of delirium, but they're a care worker. They don't necessarily know or have the capabilities to pick that up. But wouldn't it be great if we could actually Zoom in a healthcare provider to be able to assess that person, work with the care worker, work with the GP, the family, and to put some early interventions in. So I probably am quite futuristic. I appreciate that there's already technology here that is being used, but sometimes I feel that people have developed technology and then come to health or to consumers and said, I've got this great product for you. And you go, well, what would I do with that? Whereas I think we actually need to be saying, what's the problem and what's the technology of the future going to do to address that, to enable me to be as well as possible and to stay safely in my preferred place of care. And also it has an opportunity in terms of education as well, timely medical and nursing support, and it will help to address the workforce issue, which is, it's bad now, but I think it's going to be really tougher in the future.
Yeah, so really, again, recognising the technology, there's all sorts of technological advances, and how do we apply and use those most effectively to the sorts of issues that you've all been talking around social connectedness, around getting that really good assessment and early intervention, and also promote sort of healthy behaviours. Thank you. Yes, really important point to think about how that might be applied. Because again, we often have assumptions about the use of technology and that it can't do those things, but we've really got to think through how best to design that. So I think now we might, if it's okay, we might sort of go to the room and also on online if people have questions, because I'm really interested to hear from you as to, you know, the sorts of issues that have been discussed here today. They're very broad, very complex, but also really give us some very practical and important actions that we might really need to continue to advocate for. Questions from the room? Thank you. There's one over here. And if you could introduce yourself as well, that'd be great. Thank you.
I'm Stacey Norton, a geriatrician and palliative care consultant with Metro North. I think everything that everyone said has been fantastic. The one thing I probably notice and see a lot day to day is there's a misperception that old people want to live as long as possible. And I really think it's a lot about dignity of choice. And many older people would actually the statistics say, rather pass away than become incontinent and have someone else have to care for them. So maybe if we could actually put the person's choice about what's important in their life and when they might want to not go to hospital or when they actually would prefer to not have treatment, rather than trying to prolong that life with supports that they may actually not want for a quality of life that they don't really want.
Yes, really important point, and we haven't really talked about those sorts of issues around advanced care planning, or we mentioned it but haven't really talked in detail. Wendy, did you want to comment?
Oh, look, that's a great point that you make, and if I think of our model, our approach to ageing in the community, I think you're right. When we meet our clients, we're asking questions like, tell me a little bit about you. What would you like to achieve? Because as you said, it might not be to live the longest life they can, but the best life that they can in the way that they can. What's your general health like and what's stopping you do things? And I guess advanced care planning is a really interesting topic, and I think during especially this Omicron wave, we saw with a lot of our residents in aged care that their families and possibly them, even though they'd had discussions about not wanting to go to hospital, when the time came, they did. So I guess it's that ability to change and understand, but if you don't have those conversations, then you actually don't know what your client wants. I guess some of the transformational change that needs to happen it's the structural change to the Support at Home program, which obviously has come out of the Royal Commission, and the funding for aged care. Our system at the moment does not take a human rights approach like it does for people with disabilities. So I think it was Alison or Margie was saying people wait for care, they wait for a package. If you're assessed as having a need, there shouldn't be that need to wait, because that actually will change your ability to age and live where you want to live. So if we go back to, is it a real possibility to live well at home? From a human rights perspective, people should live where they want to live and die where they want to die. So there's got to be a lot of structural change to the new programs, approach it in a different way. And I guess we're on the brink of that because it's a whole of society issue. And the thing about ageing is, I guess most people don't want to age, but if you get to age, you're actually one of the lucky ones, because as we know, there's a lot of people that don't get that opportunity to age.
Darren?
Just to add to that, I think the other thing that I've observed over the years is we probably need to be talking more about what happens as mum or dad age, and what does that mean for us as a family caring. And I can think of multiple examples where I've sat down when I was working in aged care to have chats with family to go, I can see why you want this for mum, but this is what we're hearing mum wants. And the family's having a real difficulty in dealing with that. They go, no, that's not what mum wants. And we've spent a lot of time with mum getting to this point. So I think bringing that out in the open, having more conversations about how do we care for our family members as they age would be a really healthy conversation.
Deborah?
Good morning. Deborah Pryor, aged person, retired, etc., etc. What intrigues me is that we're talking as a collective term of ageing. Now, I understand that Eric Eriksson's well-known psychologist of psychosocial development. When he died, his wife identified he'd missed out a phase, which is aging. Now, I think it's a given that we age for 30 years, 40 maybe. I just wonder whether, you know, what work has gone into sort of looking at those developmental stages of aging and whether they're actually addressed. I mean, where I'm living at the moment is a retirement community called Somerset, and active, cognitively intelligent people, but all the time marginalised in terms of, you know, we've got to get ill, we've got to get immobile before we're addressed as, you know, we're part of that collective called the age, where there's many different phases. And that's a big question. The other one was related to technology, where technology is all very well, but there's a lot of old people because of physical difficulties. You know, you start with you can't operate technology. Sorry, big one.
So, okay, we'll go Wendy and then we'll, yes.
Oh, thanks for that, Deborah. We actually conducted a health and wellbeing survey for all of our residents living in our retirement village with the Bolton Clark Research Institute. And it was pretty important to us because we're providing homes, property, but what that actually told us is that that ageing process and that there is a variety of people living in our retirement living. They're not, some are very active, some aren't, and having that knowledge can help deliver services that addresses that and acknowledges the fact that not everyone is in the same stage of ageing.
If I can add to that, Stanford's done a lot of work on, if you Google new map of life, and that's trying to change the paradigm of saying when we're talking about ageing, we're just talking, you know, somebody in their sort of final years. We actually need to be looking about the whole lifespan and how do we age over that lifespan and what are the major transition points and how does that affect us as we get older. So I think there's a paradigm change we've got to have and say, just stop talking about this, you know, group over here. It's all of these people living their lives from a very early age to old age, and that's the conversation that we've got to be having as a community.
In regards to your point about technology, I agree. The technology probably isn't being developed in co-design with the older person to make sure that they can use it. And I'll give you an example of this. I have just recently trialled some technology with a group who went ahead, developed this lovely piece of technology and wanted to get evidence that this changed depression. And we sent it out to residential aged care and for people living in their homes. And it was around, you know, had big tiles so that the person just had to click on it and then they would be able to connect with their family, click on another tile and they could have entertainment, click on another one and they had, you know, games to play with, that sort of thing. So the concept was good, but as you said, many of their physical changes that occur with ageing and all of the people that we're dealing with had the problem, couldn't actually activate the touch screen because their hands were too cold to do that. And so at the last minute, we had to go and find stylists for them to use to compensate for that. Whereas if we'd actually involved the person right from the start, and Jane, you did mention that, we wouldn't have had that problem, I don't think.
Deborah, I totally agree. Not all technology is appropriate for older people, and I think a lot of it hasn't actually been designed with them in mind or partnered. But I think there is a really large piece of thinking about technology, especially for new models of care, whereby we've actually integrate or augment technology into existing workforce models and the way in which we're caring for people so that we can actually deliver more care or triage more care for older people, or it doesn't just apply to older people, and I'm thinking more about palliative care patients that I'm most familiar with looking after, that we can actually get timely clinical care to them and respond in an appropriate way before their condition actually deteriorates or escalates. I think there are great opportunities, and also too that we do away with this postcode lottery that still exists in Australia with a universal healthcare system, whereby often the care you're receiving is really dependent on where you're actually locating, whereas everybody really needs to have best evidence-based, culturally safe care in whatever bed or situation they find themselves. So that's probably the piece of technology I'm most interested in thinking about how can we augment it to deliver better models of care and prepare the workforce, the health workforce, to be able to adapt to that model. And I'll give you an example. Silver Chain, who's a very large home-based palliative care and community nursing provider, used to just be in WA, but now in many parts of Australia, probably about 5 or 6 years ago, they did a small-scale project actually using the HoloLens. So they were projecting using a hologram into patients' houses to enable doctors and nurses to assess the patient in real time. The interesting thing about that was the patients actually didn't mind having the hologrammed clinician in the room and weren't distressed by it, but in actual fact, the doctors and nurses didn't care for it. And so to me, that actually really speaks to, you know, we've got a lot of work to do, not only with the technology to make it more seamless, but also to prepare the workforce.
We'll take your question, then I'm going to take a question I've got here from online as well. Thank you.
Okay, my name is Confident. I'm a student, a research student at the School of Nursing. So I'm from West Africa, and I'm actually interested in the engaged model that Alison talked about. We are not going to have engaged model very soon because of funding challenges, but we care for other people in the hospitals. So I was going to ask, apart from the engaged model, do you actually provide some professional training to your staff about how to have compassion or empathy for other people? And just tell me a few areas, a topic you touch on if you do that, so we can actually learn from your system. Thank you very much.
That's a really good question, Confidence, and it probably, I just might sort of add, it relates to one of the questions we've got online, is from someone who really is concerned, as an older person who's extensive knowledge, extensive career, and talks about rampant ageist attitudes and a lack of sort of perceptions of empathy from people who are caring.
Yeah, look, and I think this is a really important issue, and we did some nice work. We did a statewide survey through the Older Persons Clinical Network of older person-friendly practices and processes right around the state, and then we did some really detailed interviews with clinicians, managers, consumers, and academics as well, to look at what was sort of underpinning some of the gaps in age-friendly processes. And I think this issue of compassion was a really big one. So we can talk about developing knowledge and skills, but attitudes are really critical. And we know, you know, all of us are just part of the society that we come from. We know that our society and the world mostly are very ageist, and that we bring that ageism in all sorts of subtle ways: internalised ageism, externalised ageism, institutional ageism, and the mechanisms for combating that are really tricky. So even today, when I'm listening to our mutual conversation, we talk so much about they, don't we? They are ageing. Mm-hmm. And ageism is a fascinating form of discrimination because it's discrimination against our future selves for most of us, right? So it's not an us and them, and we need to have a lot more conversation about us, because each one of us is aging. Actually, we're just at a different part, some of us further along than others. So we need to remove the us and them discussion, and we need to, and there are two things that the WHO report on ageism tells us can help, and one of those is experiential learning. So where we're, and I think that is a real problem in health professional education, because we can do lovely teaching in undergraduate curricula, but if our students are then spending time in clinical placements where they're seeing and hearing non-compassionate or ageist attitudes, and we know that does happen, then what we are saying is not gelling with what they are seeing, right? And I think a lot of students find that really difficult, and
And so they have their compassion extinguished by seeing a highly task-focused and task-rewarding environment, right? So we need to move away from a task focus to a person focus, and we've talked a lot about that today, but it is still aspirational. The second thing, and I was really interested in your comment here, Darren, is intergenerational contact. So if we have students who actually have never had a conversation with their granny, then, how do you learn those skills about how you might need to modulate your pace or your volume or your or just how you frame things for people from a different who have had a different experiential background, who might have different abilities, and so there is an Institute for Intergenerational Learning, and I'm sure you've all seen and loved the Old Person's Home for 4-year-olds, by my colleague Sue Curl, and there are some beautiful examples, but we're still not seeing them well embedded. We have paediatrics, we have geriatrics, we have multiple organ specialties in between in my world of hospital care, and we don't really think about how to cultivate intergenerational contact, how to cultivate real opportunities for us to identify, reflect on, and internally challenge the ageism that we see in small things and conversations every day. So we have a really long way to go, is a long sort of answer to that. And I think lots of us are trying to do our best in little pockets of curriculum, but we need a much more integrated approach across all of our disciplines, professional and non-credentialed staffing, but also longitudinally, because we can make our students great, but if every senior staff member they're seeing is encompassing discriminatory or stereotyped behaviours, then that becomes a very poor investment.
Thank you. Did anyone else want to comment on this? Is obviously really getting at the heart of some of the really significant issues we've got to address. We've talked about a number of structural issues, but and the structural issues does influence really how compassion is able to be developed and really a key part of our work. Wendy?
Look, some of the work the Bolton Clark Research Institute's been doing for a while now is around life stories and intergenerational learning, and I can see Xanthi smiling over there, our researcher, who coordinates the program. So we've engaged with local schools, and those school students as young as 12 have been interacting with our residents and collecting their life stories. So it's part of that being too that what comes with age is often wisdom, and when we're interacting with older people in our service, if we don't take the time to get to know them, we're missing a part of them. And we've got some lovely examples through the work with the life stories, where we've also got older school students and some of our lifestyle therapists collecting stories. We then create a book with that. And what we've found is when the resident or our client passes away, we actually give that book to their family. And some of the feedback we've had is that they learnt something new about their mum and dad that they didn't know before. When our staff do the life stories with these people, they get so much joy out of it, because they're seeing photographs of the person in their younger years and what they did with that. So it's that wisdom and that collective understanding that people have something to offer, especially a young person. And it's created a lot of opportunity, a lot of great feedback, and we just want to spread it even more than we can.
I love hearing about that. It's an extraordinary program. Yeah. I think we'll have one last question. I think there was someone in the table here who had just one last question before we have to wrap up. Yes.
My name's Ross, and I'm 4 years into my sentence of vascular dementia, and my concern is about housing. I've heard it try to get into the discussion a bit this morning, but I'm always surprised that it seems that there's nobody from any of the states of Australia who've gone over to Britain and seen what they've done in the last 20 years with aged housing. They put all the funds through the local councils for the construction or development of little cul-de-sacs of village housing, properly placed to the resources they need. And so it's sort of just a second idea instead of having aged care homes.
It's critical, isn't it? So maybe, yes, Wendy and then Margie, just a brief comment. Thank you.
I've actually been to the UK and seen that there, so I totally agree with you. I guess Australia is a little bit behind that. Some of the buildings that Bolton Clark are looking at, and we've just completed one in Melbourne in the inner city, is the assisted living design. Okay, so independent units, but they're designed so as you age and as your condition changes, services can be brought into there to allow you to stay exactly as you said in a housing that's designed for that purpose. So that was opened in November last year, and if the construction industry gets more staff, there'll be more on its way.
Wonderful. Margie, did you want to have a comment? I know this is your area. Oh, sorry, Russ. Yeah.
We mustn't assume that everybody has home ownership.
Yes. So we're thinking about access for all as well. So, yeah. Margie?
I was just going to say, dare I say, Queensland is a little behind in this. In New South Wales, in Sydney, in suburbs, there are purpose-built homes that are aged care group home type things, where they do have carers living there. So one person who takes the role of a carer, and then there are people with different types of conditions and people living with dementia as well. So it is happening. It's just happening slower than other countries.
Thank you. And Darren?
Just a quick one. The Premier recently announced a housing summit for Queensland. Let's see if ageing is on the agenda and what that might mean for us.
Wonderful. Thank you. Look, thank you so much, everyone. I've got a whole lot more questions online that have been handed to me, and I'm sure there's many more in the room. This is obviously a conversation where there are so many layers and so many really important issues that we need to discuss. And I think, we started with our topic of ageing with dignity, living well at home. Is it oxymoron or a real possibility? And I think while we are well aware that there are significant issues and challenges that we have to face at multiple levels, I think what we've heard from the panel here today is that it is a real possibility, that there are some very practical and important things that can be done. Yes, we've got big system and structural issues, but it's great that we've got advocates like Darren. It's great that we've got leaders in the system such as Wendy and Alison and Margie and Jane, and great that we've got people who are committed to research and education. And I'm really pleased that our older people, our consumers in the room, have contributed to this conversation today, because again, one of the key messages that I think we take from this is that this is really about us as a community and how we all work together to really have the best possible lives for all of us throughout our lives. So thank you all for attending. I really, just can we maybe applause for the panel? It has been a really most interesting and challenging discussion, I think, and lots of food for thought. I would just say as you leave, we've got time for sort of some networking and discussion outside if people want to stay around and have discussions. I'm sure there's more coffee and everything else for people out there. As I said, this is a part of our Real Health Lecture series, and if you're interested in just keeping up to date of other events, panels, lectures that we might have that might be of interest to you, there is a little card on the table with a QR code. You can just take that away and register for the Best of Health newsletter, and you'll get updates of what's coming up and along. Can I thank our team who've put the event together, Sally Stewart, Caitlin, where's Caitlin? Oh, there she is, just hiding around the back there, thank you. As well as some of the other sort of volunteer staff who've come in early today. We've got all the kids organised to come in early and actually help sort of with registration and everything. Again, please enjoy the company and thank you all for coming along, and thank you everyone.